Welcome back to the Deep Dive, where we plunge into complex topics to distill the essential insights you need fast. Today, we're tackling a compelling clinical challenge that for decades has left patients and clinicians navigating, well, incredibly limited options.
That's right. I mean, for such a long time.
Yeah, think about it. The standard of care for patients suffering from transfusion-dependent anemias, whether it's the thalassemia or certain myelodysplastic syndromes, what we call MDS, it was largely just supportive care, wasn't it?
Absolutely. Managing symptoms, regular transfusions, a heavy burden for patients. We
Yeah.
weren't really fixing the underlying problem or aiming for true independence from blood transfusions.
Exactly. But now there's this pivotal question emerging. Can Luspatercept offer that sustained independence for these patients? It's
Yeah.
a really fascinating novel erythroid maturation agent, an EMA, with a truly unique mechanism.
It really is. It tackles the problem differently.
Right. Imagine your body's red blood cell factory. Sometimes that factory gets stuck, or maybe it's just not producing healthy cells efficiently. Luspatercept steps in as what they call a transforming growth factor, or TGF-fall superfamily ligand trap.
Which, in simpler terms, means it's sort of unblocking a jam in the production lines.
Yeah, precisely. It inhibits, or rather, it traps certain signals, specifically involving SMED23 signaling, which then helps jumpstart and promote the maturation of red blood cells. It's designed to help your body get its own red blood cell production line back on track,
Kicking ineffective erythropoiesis to the curb, essentially.
Exactly. And this isn't like brand new off the shelf. The FDA initially approved Luspatercept back on April 3, 2020. That was specifically for lower risk MDS with ring sideroblasts, MDSRS, particularly after patients had failed ESAs, erythropoiesis stimulating agents.
Based largely on the Medalist trial data.
Right. But then, and this is a pretty big deal, in August 2023, its indication was significantly expanded.
Yeah, that was following the Commands trial. Big news.
Huge. It now includes lower-risk MDS, regardless of ring sideroblast status, and even for patients who haven't had ESAs yet, the ESA-naive population.
Which opened it up to a much wider group of patients.
Absolutely. But today, we're not just rehashing the trials. Our deep dive is all about the real-world evidence. We want to move beyond those highly controlled, often very carefully selected patient populations in clinical trial.
The perfect patients, sometimes.
Right. And see how Luspatercept truly performs in the diverse, messy, wondrously complicated reality of everyday patient populations out there. How does it stack up when the rubber meets the road?
And that's precisely why this real-world data, RWD, is so utterly indispensable. While those rigorous clinical trials, they give us the foundational evidence for efficacy and safety in a very controlled setting.
Almost like a lab setting, yeah.
Exactly. RWD captures how a treatment actually performs in a much broader, far less selected patient population. We're talking about patients with a full spectrum of comorbidities. Maybe they've had lots of different prior treatments. And critically, you see real-life adherence patterns.
Things you just can't replicate perfectly in a trial.
You really can't. Real-life adherence isn't monitored quite so strictly. So RWD offers a far more complete, more nuanced picture. It reflects the true challenges and also the successes of day-to-day clinical practice.
Okay, so what have we gathered for today's deep dive? What's the scope here?
Well, we've pulled together insights from an impressive stack of studies, somewhere between 10 and 12 real-world studies. And these aren't small studies either. They span thousands of patients across quite different regions.
Like where?
We're looking at vital data coming out of the U.S., Italy, Greece, Turkey, Czechia, and even China. So a really wide geographical and, clinical scope.
That variety must be important.
It's crucial. It allows us to see truly diverse patient experiences and also different practice patterns depending on the healthcare system. And the indications covered are equally diverse, giving us a pretty comprehensive view. We're looking at its use in transfusion-dependent thalassemia, both the major form, TDT, and the non-transfusion-dependent NTDT, as well as lower-risk MDS.
And within MDS, still focused on the ring sideroblasts.
Yes, specifically those with ring sideroblasts, the MDSRS group, but also, importantly, those with SF3B1 mutations, which often overlaps but isn't always identical. So our mission today is really to extract the most important, the most actionable insights from all this material. We'll be focusing on Luspatercept's effectiveness, its safety profile in the real world, and, crucially, its practical application. How are clinicians actually using it?
Okay, fantastic. So before we dive into the effectiveness, the does it work question, let's get a clearer picture of how we know what we know. You mentioned 10, 12 studies, different regions. What kind of studies are we actually talking about here? It's not all the same type of research, is it?
No, not at all. And that's actually one of the strengths here. We're looking at a fascinating mix of methodologies, and each one brings a slightly different angle, a unique perspective to the table.
Like what, for example?
Well, we've got retrospective cohorts, where researchers look back at existing patient data. Then there are large healthcare claims database analyses. These give us a really broad population-level view, often covering thousands of patients.
Kind of the bird's eye view.
Exactly. Then you have electronic medical record, or EMR-based audits, which can offer much more detailed clinical insights from patient charts. And finally, there are even prospective registries, where patients are enrolled and followed forward in time. So this variety gives us a really comprehensive perspective on how luspatercept is being used and how it performs across all these different real-world scenarios.
Can you give us a couple of examples just to illustrate that breadth?
Sure. So on the large-scale end, there's the study by Andretsons and colleagues. This used a U.S. healthcare claims database, and it was huge, 871 patients with MDS. It gave us that broad epidemiological view, looking at transfusion patterns before and after luspatercept, stretching from 2010 all the way to late 2022. It helped understand use across different baseline transfusion dependencies, prior ESA exposure, RS status, all that big picture stuff.
Okay, so that's the massive claims data approach. What about something more maybe clinically detailed?
Right. Then you have something like the study by Lenito and colleagues out of Italy. This came from a compassionate use program focusing on 201 MDS-RS patients. What was really notable there was the high prevalence of comorbidities in their patients' median age was 74, lots of other health issues.
So more like the complex patients you actually see walking into the clinic every day.
Precisely. It really highlights how luspatercept performs in a potentially more fragile, maybe more complex real-world cohort compared to the often cleaner trial populations.
Makes sense. So we have large databases, compassionate use. What about multi-center studies looking across different hospitals or clinics?
Yep, we've got those too. Buchele and colleagues provided a really robust multi-center perspective from Greece and Turkey. They looked specifically at 98 transfusion-dependent lower-risk MDS patients who had already failed ESA therapy. So that gave us a broader European lens on efficacy in that specific post-ESA setting.
Okay. Any others like that?
Similarly, Yonisova and colleagues offered insights from 2 Czech hematology centers. They focused on 54 transfusion-dependent LR-MDS patients, but they included a really diverse range of MDS subtypes, which is interesting. And their study had a notably longer median follow-up, about 17 months, giving us a bit more of a glimpse into sustained outcomes.
And what about drilling down into just one hospital's experience? Sometimes those single-center studies offer really deep insights, don't they?
They absolutely can. We have Farouk and colleagues from the Mayo Clinic in the U.S. Now, this was a smaller study, 39 MDS-RS patients, but it was highly detailed. These patients were often heavily pretreated, having received multiple therapies before luspatercept. It really highlighted the challenges and the outcomes in that kind of difficult-to-treat tertiary care referral setting.
Okay. And you mentioned China earlier.
Yes. Zhang and colleagues provided a multi-center study from China focusing on 23 patients with relapsed or refractory lower-risk MDS, but specifically those with SF3B1 mutations. That's a really crucial genetic subgroup. So this study gave us a unique perspective on that particular patient population and also how luspatercept is being used in clinical practice in Asia.
Got it. And you also mentioned Thalassemia earlier. Was there a study specifically looking at that group? Because that's quite different from MDS.
Exactly. A very different underlying disease. Torti and colleagues from Italy gave us a very focused look, albeit at a smaller cohort of 10 transfusion-dependent thalassemia, or TDT, patients. It's small, yes, but it provided specific, valuable insights into luspatercept's role in this distinct inherited blood disorder.
Wow. Okay, so it's quite a mix then. Big data, specific programs, different countries, different disease subtypes.
It really is. And what's fascinating is how these studies capture different angles. You have the large claims data giving you the broad strokes of real-world use patterns. You have country-specific compassionate use programs or multi-center studies offering insights into diverse populations and healthcare systems. And then the smaller single-center studies let you dive deep into specific clinical characteristics or treatment pathways.
And the patients themselves sound different from trial patients, too.
Definitely. Across the board, the patient populations in these real-world studies are notably older, often median age in the mid-70s. They're frequently more heavily pretreated, having failed multiple therapies before getting luspatercept, and they tend to have more comorbidities than the patients typically enrolled in the pivotal trials. And that, right there, is a critical aspect of assessing real-world applicability.
Because that's the reality of clinical practice.
That is the reality. So this diversity in disease indications, patient characteristics, geographical origin, study methodologies, it allows us to build a really robust, almost panoramic picture of luspatercept's performance that goes way beyond the initial trial findings. It's truly seeing how the drug functions in the hands of real clinicians, treating real patients with all their complexities.
Okay, that sets the stage beautifully. We have this incredible foundation of real-world data from all sorts of angles. So here's where it gets really interesting. How effective is luspatercept truly proving to be in these, let's say, less controlled, real-world scenarios? Are patients actually getting off transfusions or at least needing significantly fewer? Let's start with that key endpoint. Transfusion independence and burden reduction, particularly in MDS.
Yeah, this is obviously the million-dollar question for many patients and clinicians. And the data overall is quite compelling. What's clear across the board is a significant reduction in transfusion needs for many patients.
Okay, give us some examples. What did the big studies show?
Well, let's take the Indritzo's U.S. claim study again, simply because it was the largest. It showed luspatercept to be highly effective in achieving transfusion independence, or TI, or for those not dependent at baseline, maintaining non-transfusion dependence, NTD. Overall, a really striking 87.4% of patients achieved at least 8-week TI or maintained 8-week NTD within the first 6 months of starting treatment.
87%, that's huge. How did that break down?
It gets even more impressive for some subgroups. For patients who are already NTD at baseline, meaning not needing regular transfusions, an amazing 98.5% maintained that 8-week NTD status, and 88.6% maintained it for a longer period, 24 weeks.
Wow. Okay, but what about the patients who are transfusion dependent to start with? That's often the tougher group, right?
Absolutely. And even there, the results were substantial. Among those baseline TD patients, 64.2% achieved 8-week TI. Now, that number did drop when looking at a longer time frame. It was 30.5% achieving 24-week TI. But getting over 60% off transfusions for at least 2 months is still a major win for many.
Definitely. And did it matter if they had ring sideroblasts or not? Because the initial approval was just for MDS-RS.
That's a really interesting and nuanced point from the Indritzo's study. They found that the TI rates were actually quite similar between the MDS-RS patients, 89.8% for 8-week NTD TI, and the MDS non-RS patients, where it was 84.8%.
Huh. So similar effectiveness even in the group it wasn't initially approved for.
It seems so, at least in this large real-world data set. It's a crucial finding, especially given that initial, more restrictive indication. It really suggests that clinicians were likely using it pragmatically in non-RS patients even before the label officially expanded, perhaps based on clinical need or lack of other options.
Fascinating. What about other studies? Did they see similar TI rates?
Generally, yes, though the exact percentages varied, which you'd expect with different populations and methodologies. The Lenino-Italian MDS-RS study, for example, found TI for 8 weeks or more within the first 24 weeks was achieved by 30.8% of patients. But that increased to 39.3% when they looked over a longer period, 48 weeks.
Okay, a bit lower than the U.S. claim study, but still significant.
Still significant. And what both the Lenino study and Buçla's Greek and Turkish study really highlighted was a consistent trend. Buçla saw 42.9% respond overall. And among those followed long enough, 44.3% achieved TI lasting over 8 weeks. But the key trend they both found.
Let me guess. It depends on how many transfusions they needed beforehand.
Bingo. Patients with lower baseline transfusion needs consistently had significantly higher TI rates. For instance, in Lenino's study, patients needing 4 or fewer units per 8 weeks had a 55.8% 8-week TI rate. Compare that to only 25.6% for those with a high burden, needing 8 or more units every 8 weeks.
That's a big difference, more than double the chance if you start with a lower burden.
Exactly. And the Onisova Czech study further reinforced this. They reported really impressive overall TI rates, 62.7%, achieving at least 8 weeks TI, and nearly half, 49%, achieving at least 24 weeks TI. But again, the response was significantly higher in the low transfusion burden group compared to the high transfusion burden group. The Zhang Chinese LR-MDS-SF3B1 study echoed this pattern too. 57.1% of their transfusion-dependent patients got 8 weeks TI within the first 12 weeks, but the hematologic improvement rates were way higher in the NTD or low transfusion burden groups.
It seems like a really consistent finding across different countries, different healthcare systems. Baseline transfusion burden is a major predictor.
It really seems to be. It's almost like, the drug works best when it has a little less heavy lifting to do right from the start. It strongly suggests that maybe intervening earlier, before the transfusion burden gets very high, could lead to better outcomes with luspatercept.
That's a huge clinical takeaway right there. Especially in lower burden patients. Beyond just getting off transfusions, though, what about the direct impact on actual hemoglobin levels? Are we seeing those numbers go up? Because that's often tied directly to how patients feel.
Absolutely, and that's another key piece of the puzzle. We did see significant improvements there, too, across studies. For instance, the Zhang Chinese study specifically reported that the median hemoglobin concentration significantly increased. It went from 61 grams per liter at baseline up to 84 grams per liter at week 12. And that was statistically highly significant.
So a real bump in hemoglobin.
A real bump. And even in the context of thalassemia, the Torti Italian study found that the mean pre-transfusion hemoglobin values, so the lowest point before the next transfusion, increased significantly. They went from 9.3 grams per deciliter up to 9.7 grams per deciliter after 12 weeks of luspatercept, even while patients were getting fewer transfusions.
That's critical, isn't it? Because higher pre-transfusion hemoglobin means less profound anemia between transfusions.
Exactly. It translates directly to less fatigue, potentially better organ function, and generally a better quality of life for the patient between those necessary transfusions, even if they don't achieve complete independence.
Okay, so we're seeing impressive initial responses, hemoglobin boosts. But the question always is, how long does it last? Is this a durable benefit we're talking about? Or are patients enjoying a brief transfusion holiday only to relapse quickly? What did the real-world data show about the duration of response?
That's a critical factor, especially for managing chronic conditions like MDS and thalassemia. Quality of life depends not just on responding, but responding for a meaningful amount of time. And the data on duration is quite encouraging, actually, though variable.
How so?
Well, the Bushla Greek and Turkish study reported a median duration of response that was really quite impressive, 32 months.
32 months. That's over 2.5 years.
It's exactly a very encouraging median. They also noted that even some of the high transfusion burden responders, the tougher group, showed responses lasting longer than 6 months, which is positive news for those patients.
Okay, that's one study. What about others?
The Lenino-Italian MDS-RS study found the median longest duration of primary response was 23.9 weeks, so closer to 6 months in their cohort.
Still a decent chunk of time off transfusions for many.
Absolutely. And in the Farouk US MDS-RS study at Mayo Clinic, remember, their cohort was heavily pretreated. Their overall response rate was more modest, around 18%. But importantly, among those who did respond, the median duration of response was 6 months, which they noted was quite comparable to the 8 months seen in the Medalist trial.
So even in a tough-to-treat group, the responders held that response for a similar duration to the trial.
That's what it suggests. And one more data point, the Yonisova-Czech study. They had 38 responders initially. Over time, 8 of those patients, about 21%, did become transfusion-dependent again. But that happened after a median of 12 months.
Meaning nearly 80% were still responding at the 1-year mark.
In that particular cohort, yes, it indicates a good degree of durability in a significant portion of patients, although clearly some do eventually lose response over time, which is expected with MDS progression. So the big takeaway here isn't that every patient achieves an indefinite response, because that's often unrealistic. But for many, the benefit appears to be sustained for a meaningful period, months, sometimes years, providing a much-needed break from that relentless cycle of transfusions.
That makes a huge difference. And speaking of making a difference, what about the actual tangible impact on patients' lives? We're talking beyond just lab numbers and transfusion logs. Are we seeing improvements in patient-reported outcomes? Like fatigue, energy levels, overall quality of life?
That's such a vital question, isn't it? Moving beyond the clinical metrics to the actual human experience. Now, it's fair to say that not all of these real-world studies, rigorously collected formal patient-reported outcome questionnaires or PROs, is often harder to do systematically outside of a trial.
Sure, that makes sense.
But the Macellum Review on Thalassemia, which included a detailed clinical case study of a patient named Maria, offers a really powerful glimpse into this. Maria was a 32-year-old with thalassemia major, and the report highlighted that she experienced significantly improved general energy, even though her transfusion regimen was actually reduced while on luspatercept.
So fewer transfusions and more energy. That sounds like a win-win.
Exactly. And this might seem like a small detail on paper, but the review really emphasizes what this means for patients like Maria. For them, those regular transfusions, the constant hospital visits, they're incredibly inconvenient.
It must dominate their lives.
It really can. It significantly disrupts social integration, work patterns, family life, just overall enjoyment. Imagine having to schedule your entire life around hospital appointments, planning for the fatigue before your next transfusion, the time it takes for the transfusion itself, the recovery afterwards. It's a huge burden.
Yeah, you don't often think about all those logistical and personal impacts.
Right. And novel therapies like Luspatercept are specifically aiming to reduce those transfusion requirements and, as we saw, improve the pre-transfusion hemoglobin levels. And that improvement, that reduction in burden, directly translates to a better quality of life. It gives patients back some normalcy, some freedom, some energy. Even if it's not a complete cure, reducing that burden is hugely meaningful.
That's a really important perspective to keep in mind. Okay, so if we pull all this effectiveness data together, the transfusion independence, the hemoglobin bumps, the duration, the potential quality of life impact, what does this all mean when we compare it back to those big, pristine clinical trials like Medalist, Commands, Believe for Thalassemia, Beyond for non-transfusion-dependent thalassemia? Are these real-world results holding up against that gold standard? Or, perhaps more interestingly, are they telling us something different, something new?
Yeah, this is a really important question and something clinicians always grapple with when a drug moves from trials to practice. Do the trial results translate? And what we often see with real-world studies is that they can show different, sometimes even better response rates than the controlled environment of the pivotal trials. And that certainly seems to be the case in some instances here with Luspatercept.
Better. How so?
Well, take the Andritzen's U.S. claims study again. They observed higher 8-week transfusion independence rates for those transfusion-dependent ES-exposed patients, 64.2% in their real-world cohort, compared to the 38% reported in the original Medalist trial for MDS-RS patients.
Wow, that's a pretty substantial difference, 64 versus 38%. Any idea why?
The authors suggest a couple of possibilities. It might be partly due to a higher proportion of patients in their real-world study having a lower baseline transfusion burden compared to the Medalist cohort. As we just discussed, lower burden predicts better response.
Ah, okay. So maybe in the real world, clinicians were selecting patients perhaps unconsciously who are more likely to succeed.
That's certainly plausible. It highlights how patient selection, even outside the strict criteria of a formal trial, really impacts outcomes. But there's another possibility, too, related to how treatment is managed.
Go on.
We'll get more into this later, but real-world practice often involves more aggressive dose escalation or even combination therapies compared to strict trial protocols. But sticking with comparisons for now, the Lenino-Italian MDS-RS study found a response rate that was actually quite comparable to the Medalist study.
Okay, so not better, but similar.
Right. But what's particularly notable there is that their real-world cohort was, on average, older and had significantly more comorbidities than the Medalist population. So achieving a similar response rate in a more frail, complex group, that suggests a pretty robust effectiveness that translates well, which is a real testament to the drug's applicability in typical clinical practice.
That's a great point. It holds its own even in tougher patients.
Yeah.
Any other comparisons that stood out?
Well, the Ferg study from Mayo Clinic urged a bit of caution against direct comparison, just because of the differences in study design and the sheer heterogeneity of real-world patients. Remember, their patients had often received multiple prior drugs.
Right, much more complex treatment histories.
Exactly. But despite those differences, they found that the median duration of response they observed, 6 months in the responders, was pretty comparable to the 8 months reported in Medalist. So, again, suggesting the benefit holds up reasonably well.
Okay. And you mentioned one study reporting higher rates than Medalist and potentially explaining why.
Yes, that was the Yonisovicek LR MDS study. They actually achieved a remarkable 70% transfusion independence rate in their RS-positive patients compared to that 38% in Medalist.
70%. Okay, how did they explain that?
They attributed this significantly improved real-world outcome to 2 key factors in their clinical practice. First, they frequently used higher doses of Luspatercept, escalating up to the maximum 1.75 millikilogram dose more often. And second, importantly, they often added epoetin alpha, an ESA, to the treatment regimen if patients weren't responding optimally to Luspatercept alone.
Ah, so dose optimization and combination therapy in action.
Precisely. It really highlights how clinicians in the real world may combine and optimize treatments to maximize benefit for their individual patients, sometimes pushing the envelope beyond the initial, often monotherapy-focused trial designs.
That is fascinating. It really speaks to the art, not just the science, of medicine, doesn't it? Adapting protocols based on individual response. Does this suggest that maybe the initial trial protocols were perhaps a bit too conservative, or maybe just that real-world clinicians are, by necessity, more pragmatic in finding what truly works best patient by patient?
I think it's likely a combination of both. Trial protocols need to be standardized and often start cautiously. Clinicians in practice, faced with a patient not responding optimally, are naturally going to explore options like dose increases or adding complementary therapies if the rationale makes sense. They're inherently pragmatic, always seeking to optimize for that individual sitting in front of them, and the real-world data clearly reflects that adaptive approach.
Okay, and it sounds like they're looking beyond just the red blood cells, too. You mentioned earlier we might see effects on other things, like other blood counts or that persistent problem of iron overload in transfusion-dependent patients.
Yes, absolutely. Beyond just boosting red cells, we are definitely seeing significant secondary benefits in the real-world data. And the impact on iron overload is a really important one, particularly for those chronically transfused patients.
So what did the studies show there?
The Buchla Greek and Turkish study observed that patients who responded to Luspatercept showed a significant decrease in their serum ferritin levels. That's our main marker for iron stores. The median dropped from 880 down to 691 nanograms per deciliter.
And that's not just a random finding, right? There's a clear reason for that.
No, it's not a happy accident at all. This reduction in ferritin is a direct consequence of Luspatercept helping the body make its own red blood cells more effectively. That means fewer transfusions are needed, and fewer transfusions mean less iron coming into the body. Critically, it means less of that problematic iron building up over time.
Which is huge because iron overload causes so many long-term problems.
Exactly. It can damage the heart, the liver, endocrine glands. It's a major source of morbidity for these patients. So seeing ferritin levels drop is a really crucial practical outcome.
Did other studies see this iron benefit too?
Yes, consistently. The Zhang Chinese study also reported a significant median serum ferritin reduction overall, and importantly, the reduction was even greater in the patients who responded well hematologically. The Torti Italian Thalassemia study also highlighted this, showing a remarkable 34% reduction in ferritin values after just 4 cycles of Luspatercept.
34% in 4 cycles is pretty fast.
It's quite impressive. This reduction in iron overload, driven by both improved erythropoiesis and reduced transfusion needs, is potentially a game changer for long-term patient health and quality of life. It tackles one of the biggest downstream consequences of chronic transfusion dependence.
Okay. And any hints about effects on other blood cell lines, like white cells or platelets?
There were some interesting hints, yes. The Buchla study, for instance, noted an overall increase in neutrophil counts across their entire patient population treated with Luspatercept. They also saw some patients who started with low platelet counts actually experience platelet responses.
Suggesting maybe a broader effect on the bone marrow?
It potentially hints at that, yes. Multilineage effects beyond just erythropoiesis. Now, the Zhang study also measured platelets, white blood cells, and neutrophil counts, but they didn't find statistically significant differences in the increments between responders and non-responders for those specific parameters in their smaller cohort. So it's still an area that needs more exploration, but these little signals in the real-world data suggest there might be more going on mechanistically than just stimulating red blood cell maturation.
Fascinating stuff. Okay, let's shift our focus now squarely onto safety. We've seen some really promising results on efficacy, especially regarding transfusion burden and even iron levels. But, as we always say, efficacy without safety isn't the full picture. What did these real-world studies tell us about how patients are actually tolerating Luspatercept day-to-day outside the carefully monitored environment of a clinical trial?
Right, safety and tolerability in the real world are paramount. And generally, the safety profile observed across these studies appears quite consistent with what was seen in the pivotal clinical trials. However, there are, as you'd expect, some practical nuances and specific points that are really important for clinicians to be aware of.
Okay, so what were the common side effects people reported?
Looking at the Farouk U.S. MDS-RS study, they reported common adverse events of any grade in about 23% of their patients. These included many of the things we heard about from the trials: fatigue, dizziness, some abdominal pain, muscle aches, bone aches, shortness of breath on exertion, and palpitations.
So generally, things that are noticeable, maybe bothersome, but often manageable.
Generally, yes. These are the types of side effects clinicians become familiar with managing. Now, looking at more serious events, the Lenino-Italian MDS-RS study reported serious adverse events, or SAEs, in 17.4% of their patients.
Okay, what kind of SAEs were most frequent?
The most common were cardiac events, things like hypertension, acute heart failure, atrial fibrillation, which occurred in 11 patients. Infections were also relatively common, seen in 10 patients, along with COVID-19 pneumonia in 4, and interestingly, falls leading to bone fractures in 4 patients.
Falls, is that related to the drug or maybe the patient population?
It's more likely related to the patient population.
Mhm.
Remember, this Italian cohort was older with a high rate of comorbidities. Falls are unfortunately common in frail, elderly individuals. They also noted some hematologic SAEs, grade 4 thrombocytopenia in 1 patient, and neutropenia in 8 patients. But importantly, they pointed out these typically occurred in patients who already had low counts at baseline, and they weren't necessarily correlated with the disease getting worse.
Okay, so some serious events, but perhaps expected given the patient population older, more comorbidities, underlying MDS.
Exactly. You have to interpret SAEs within the context of the patients being treated. Many of these events might have occurred regardless of the luspatercept therapy, given their underlying health status.
Makes sense. So with these side effects, how often were patients actually stopping treatment because of them? Were adverse events a major reason for discontinuation?
That's a key measure of tolerability, isn't it? And the rates of discontinuation, specifically due to adverse events, actually seem relatively low across the studies, which is quite encouraging for real-world use.
How low are we talking?
For example, the Bushlag Greek and Turkish study reported that only 8.2% of their patients discontinued treatment directly because of an adverse event. The reasons listed included things like musculoskeletal pain, vertigo, hypertension, orthostatic hypotension, soft tissue infections, a bleeding disorder, and one case where the reason wasn't determined.
Okay, so less than 1 in 10 stopping due to side effects in that study.
Right? And in the Zhang Chinese study, they noted the most frequent adverse events were things like increased blood bilirubin, fatigue, and dizziness. But crucially, they only reported one grade 3 adverse event, the bilirubin increase in their entire cohort. And even more importantly, no patient in their study discontinued luspatercept or even had a dose reduction specifically because of an adverse event.
Wow, 0 discontinuations due to AEs in that cohort.
0. And just to add another perspective, the Musalam review mentioning Maria's case in thalassemia, she initially experienced some grade 1 arthralgia, basically joint aches, but it was reportedly easily managed with standard over-the-counter pain relief, and it resolved completely within 6 weeks, without needing any change to her luspatercept treatment.
So the overall picture seems to be that while side effects occur, many are mild to moderate, manageable, and not typically leading to treatment cessation.
That seems to be the consistent message, yes. It suggests the drug is generally well tolerated in practice, allowing most patients who benefit from it to continue therapy long-term.
Okay, that's reassuring. Now, one specific safety concern that sometimes comes up with agents affecting red blood cells or bone marrow is the risk of blood clots or thromboembolic events, TEs. Was this a major issue in the real-world data?
This is a really important point, and the answer seems to depend significantly on the underlying disease, MDS versus Thalassemia. It highlights the need for tailored monitoring.
Okay, tell me more. What was the difference?
In the Torti Italian Thalassemia study, remember, a small cohort of 10 TDT patients, they reported that 2 out of those 10 patients developed severe thrombocytosis. That means their platelet counts went very high, exceeding 1 million per cubic millimeter after about 5 and 6 months of treatment.
1 million platelets. That's really high.
Very high. And this significant elevation actually led to the treatment being interrupted for those 2 patients, even though they were otherwise responding well in terms of their anemia.
Wow, so a real safety signal specifically in thalassemia.
It certainly appears so in that study. It highlights a crucial need for close, vigilant monitoring of platelet counts, specifically in thalassemia patients on luspatercept. Thrombotic risk is already a known concern in thalassemia itself, and it seems luspatercept might exacerbate that risk or the underlying tendency for high platelets in some individuals.
Okay, so caution and close monitoring needed for thalassemia. What about in MDS? Was the risk similar there?
Interestingly, no. In stark contrast, the Yonisovicek LR-MDS study, which had 54 patients, notably reported 0 thromboembolic events in their entire cohort.
0 Ts in the MDS group.
0 reported in that study. And other MDS studies like Farouk, Lenino, and Zhang didn't highlight Ts or thrombocytosis as a major issue leading to discontinuation either. This suggests that this specific risk of marked thrombocytosis and potential Ts may vary significantly by disease type. It seems less prominent, or at least less frequently reported, in the LR-MDS setting compared to thalassemia.
That's a really critical distinction for clinicians to be aware of. Condition-specific safety protocols seem essential.
Absolutely. It underscores that you can't just extrapolate safety findings from one disease indication directly onto another, even with the same drug. Tailored monitoring based on the underlying condition is key.
Okay, so putting aside AEs for a moment, while some patients stopped due to side effects, it sounds like that wasn't the main reason for coming off therapy. What were the broader reasons for dose modifications or treatment discontinuations that these studies revealed?
Yeah, looking at why treatment stops or changes gives us more real-world insight into feasibility and long-term management. Dose escalation, as we hinted at, seems very common. In the Lanino Italian study, dose increases going up to 1.33 milligrammes, and the maximum 1.75 milligene kilograms were performed in almost 60%, 58.2% of the primary responders.
So more than half the responders needed a dose increase to get or maintain that response.
It suggests that dose escalation is a common and often necessary strategy for optimizing the response in the real world. It's not always effective right out of the gate at the starting dose. Now, in terms of stopping treatment altogether, Lanino found that discontinuation occurred in 43.3% of their patients over the follow-up period.
And why did they stop?
The main reasons were lack of benefit or losing the response they initially had that accounted for almost two-thirds, 64.4% of the discontinuations. Death was the reason for about 15%, and consent withdrawal for about 5%.
Okay, so lack of efficacy being the primary driver for stopping. How did that compare elsewhere?
A similar pattern emerged in other studies. The Farouk U.S. study saw 59% of patients discontinue. Again, the primary reasons were no response for 17 patients, loss of response for 1, compared to only 3 stopping for side effects. Other reasons included leukemic transformation or transfer to hospice. Their median treatment duration was only 4 months, suggesting that for a significant portion in that heavily pretreated cohort, efficacy was either not achieved or not sustained for very long. The Bushla Greek and Turkish study had 57 patients discontinue. Again, the biggest reason by far was inadequate response, accounting for 36 patients. Only 8 stopped due to AEs, 8 due to unrelated death, and 2 for transplant. Interestingly, they also had 3 patients who stopped because their hemoglobin levels were persistently too high above 11 GDL.
Responding too well. That's a good problem to have, I suppose.
Relatively speaking, yes. It indicates the drug can be very effective, sometimes requiring a pause or dose adjustment downwards. And look at the Yonisovicek study. They emphasized that optimal response often require that gradual dose increase to the maximum 1.75 millikilogram dose. 35 patients needed it. They also reiterated how well tolerated it was, with no patients discontinuing due to AEs. However, 14 patients did stop for other reasons, mostly MDS progression, death, or noncompliance.
So again, efficacy or disease factors driving discontinuation, not toxicity?
Primarily, yes. And one last one, the Zhang Chinese study. Dose adjustment was needed in about 39% of patients. 2 patients had doses interrupted because their hemoglobin went too high, but again, no patient discontinued or had a dose reduction due to adverse events.
Okay, so the overarching message on discontinuation seems pretty clear. Dose optimization and escalation are key strategies in the real world. And while side effects are definitely present and need managing, they seem to be much less common reasons for stopping treatment compared to not achieving or losing an adequate response, or unfortunately, disease progression itself.
That sums it up very well. It paints a picture of a generally tolerable drug, where the main challenge in practice is often achieving and maintaining efficacy for the long haul, which frequently involves careful dose titration.
That's a huge takeaway for clinicians. Dose optimization isn't just an option, it seems critical, and they are clearly using it as a tool. Okay, moving from how well it works and how it's tolerated, let's explore how clinicians are actually using Luspatercept in the clinic day to day. Are they sticking strictly to the original label indications and populations, or are we seeing some real-world adaptations, maybe using it in specific subpopulations where the trial data might have been limited?
This is where real-world evidence truly shines, I think. It shows us the actual application of a drug, often revealing practices that evolve beyond the initial textbook guidelines or trial protocols. And yes, we definitely see Luspatercept being used effectively in patient profiles that truly reflect the typical lower-risk MDS patient encountered in routine practice.
Meaning the older, more complex patients.
Exactly. Studies like Lanino from Italy, Buchla from Greece, Turkey, Farouk from the U.S., and Jonisova from Czechia, they all consistently show patients with a median age squarely in the mid-70s. These patients often have significant comorbidities and frequently a history of being heavily pretreated with other therapies.
So it works in the real-world patient, not just the trial-perfect patient.
Precisely. It confirms the drug's feasibility and effectiveness in that frail, older population that is often the most challenging to treat and arguably most in need of new, effective, and tolerable options.
Okay. What about that distinction between MDS with ring sideroblasts, MDSRS, versus those without? We touched on the Andreetz's data showing similar TI rates. Did that suggest clinicians were using it off-label before the indication expanded?
It certainly points in that direction.
Yeah.
Remember, the Andreetz's study found strikingly similar transfusion independence rates in their large, real-world cohorts of MDS-RS patients, around 90%, and MDS non-RS patients, around 85%.
Which is surprising given the initial approval was RS-specific.
It is, and it strongly suggests that real-world physicians were indeed treating MDS non-RS patients with Luspatercept before the official label expansion happened in August 2023. It really highlights clinical pragmatism. If a patient has limited options, shares similar clinical needs, maybe has failed ESAs, clinicians are often willing to try a promising therapy based on the available evidence and biological rationale, even if it's slightly outside the initial narrow indication.
Especially if the perceived benefit outweighs the risk for that individual.
Absolutely. And the fact that a high proportion of the non-RS patients in that Andreetz's study were actually non-transfusion dependent might also have influenced the similar rates, perhaps indicating early adoption for those non-RS patients who had less severe transfusion burdens to begin with.
Interesting. What about other specific subgroups, like patients with the SF3B1 mutation?
Yes, that's a key molecular marker, often associated with ring sideroblasts. The Jonas-Silva study specifically noted that among their 39 patients positive for the SF3B1 mutation, almost 62% achieved transfusion independence, really reinforcing the drug's efficacy in this specific molecular subgroup. And of course, Zhan's study from China focused exclusively on this SF3B1 mutated or related MDS population.
And in Thalassemia, any specific subtypes responding better?
There were some hints there too. The Torti study observed potentially better responses in patients with thalassemia intermedia compared to thalassemia major. They also noted potentially higher efficacy in patients with non-beta-0 genotypes. Now, these are based on small numbers, but they do align with some of the subgroup analyses that came out of the larger BELIEVE trial.
Okay, and what about splenectomized patients? Sometimes treatments behave differently if the spleen is gone.
That's a good point, especially relevant in thalassemia, where splenectomy used to be more common. Torti's published guidelines for using Luspatercept in thalassemia actually advise against starting it immediately after a splenectomy, citing the potentially high risk of thrombocytosis we discussed earlier.
Right, the platelet issue.
Exactly. However, Maria's case study, the one from Nusalam's review, was actually a patient who had undergone splenectomy and was successfully receiving Luspatercept.
Ah, so practice might differ from guidelines sometimes based on individual assessment.
It illustrates exactly that. Clinicians are constantly weighing the specific risks and potential benefits for each unique patient sitting in front of them, sometimes leading to decisions that might deviate slightly from general recommendations based on that individual's circumstances.
That's fascinating how real-world practice can sometimes precede formal label expansions, explore nuances in subgroups, and even adapt general guidelines. Let's circle back to dosing patterns. You mentioned dose escalation is common. Are clinicians really pushing the dose or sticking closer to the starting point?
The evidence strongly suggests that dose escalation is not just common. It's often a necessary and beneficial practice in the real world. This is definitely not a set it and forget it kind of drug for many patients.
It requires active management then.
It really seems to. Look at the Lanino study again. While about 42% of their responders achieved their first response at the starting dose of 1.0 millikilograms, a significant majority, 58.2%, only responded after their dose was increased, either to 1.33 millikilogram or all the way up to 1.75 millikilogram.
So more responders were found at higher doses than the starting dose.
Yes. And they also found that the dose required to achieve that first response was positively correlated with the patient's baseline transfusion burden, meaning patients who started out needing more transfusions often needed higher doses of Luspatercept to get a response.
That makes intuitive sense. What about the maximum dose? Are clinicians using it frequently?
Very frequently, it appears. The Buchla study from Greece and Turkey reported that a remarkable 74 out of their 98 patients, that's over 75%, received the maximum dose of 1.75 millikilograms at some point during their treatment.
Wow, 3/4 hit the max dose.
Yeah. And similarly, Yonisova in the Czech Republic noted that the maximum dose of 1.75 mg/L was reached in 35 of their 54 patients in order to achieve what they considered an optimal response. They actually speculated that this frequent use of the higher dose might be one reason why they observed such high overall response rates in their particular cohort.
So pushing the dose might yield better results in some settings?
It might. Even in the Zhang Chinese study, dose adjustment was necessary in almost 40% of patients, and only 9% received the maximum dose. So this widespread real-world practice of dose escalation, going beyond the initial starting dose, really appears to be a key strategy clinicians are using to maximize the efficacy of Luspatercept. It confirms they're actively monitoring response and titrating the dose upwards for individual patients.
Okay, that's very clear. Dose matters, and clinicians are adjusting it. Now, stepping back from the purely clinical aspects for a moment, what about the practical side of things? Treatment adherence, cost and reimbursement, availability. These factors hugely impact whether a clinically effective drug actually translates into real-world outcomes, right?
Absolutely. These practical factors are critical and can sometimes be major barriers. On the adherence front, the Lanino study from Italy actually observed a surprisingly high compliance rate. And remember, this was in a population of frail, older patients with multiple comorbidities.
So patients were generally able to stick with the injection schedule.
It seems so, which indicates good real-world feasibility and patient acceptance of the treatment regimen itself. Patients are generally willing and able to stick with the therapy if they perceive a benefit and can access it.
Access. That brings us to cost and reimbursement, which is often the elephant in the room with newer therapies.
It really is, and it's a major hurdle globally. The Farouk study from the U.S. specifically highlighted the significant cost of Luspatercept. They cited an estimated cost of over $11,000 per 75 milligram dose to Medicare back in January 2022.
$11,000 per dose. Wow.
Yeah. And that obviously raises serious questions about cost effectiveness and, more importantly, affordability for patients, especially those without robust insurance coverage or access to patient assistance programs. If out-of-pocket expenses become prohibitive, that financial burden can clearly limit access, regardless of how clinically effective the drug might be.
A stark reminder that clinical benefit doesn't always equal real-world access.
Unfortunately, yes. And Zhang's study from China also touched on this, noting that the off-label use in their country at the time limited the number of patients they could even enroll in their study. It just indicates that access barriers, whether they're regulatory or financial, can significantly constrain not only real-world data collection, but, much more importantly, patient access to potentially beneficial treatments.
Definitely a critical piece of the puzzle. Okay, let's swing back to the clinical decision-making. Based on all this real-world experience, are clinicians getting better at identifying which patients are most likely to respond well to Luspatercept? Are there any specific criteria or predictive factors emerging from these studies that can help guide patient selection in practice?
Yes, definitely. While we don't have perfect predictors yet, these real-world studies are certainly providing some very practical observations and signals that can help guide patient selection, inching us closer to more personalized treatment decisions.
What kind of factors are we talking about?
Well, for Thalassemia, the Torti Italian study actually detailed a quite specific list of criteria they used for considering Luspatercept administration. It wasn't just about transfusion burden. They included things like having rare red cell phenotypes, issues with or autoimmunization making transfusions difficult, problems finding appropriately screened blood, low tolerance to transfusions, previous transfusion reactions, poor compliance with the transfusion schedule itself.
So a lot of factors related to the challenges of transfusion therapy.
Exactly. Plus, high transfusion requirements leading to organ iron overload, hemosiderosis, poor compliance or tolerance to iron chelation therapy needed to manage that iron, and importantly for younger patients, the need for effective contraception due to unknown effects on embryogenesis. It's a really comprehensive list tailored to the specific challenges of managing TDT.
That makes sense for thalassemia. What about for MDS? Are there emerging predictors there?
Yes, for MDS, some potentially useful clinical and lab markers are surfacing. The Farouk U.S. study identified a couple of interesting factors. They found that higher serum erythropoietin, or EPO, levels at diagnosis specifically above 80 IUL in their cohort seem to predict a better response to Luspatercept later on.
Higher EPO predicted better response. That's slightly counterintuitive for ESAs, isn't it? Usually, lower EPO predicts ESA response.
It is a bit different, yes. And they also found that having a higher absolute lymphocyte count, ALC, or a higher absolute monocyte count, AMC, at the time of starting Luspatercept were also potential predictors of response. These offer potentially practical clinical guides, though they need validation in larger data sets.
Okay, interesting. What else?
The Zheng Chinese study looked at baseline EPO levels too, but they found the opposite trend, although their cutoff was much higher. They found patients with baseline serum EPO levels below 500 IUL tended to have a higher hematologic improvement rate compared to those above 500 IUL, 77% or S 40%. They also confirmed, as we discussed, that being non-transfusion dependent or having a low transfusion burden at baseline predicted a better response. So the EPO story might be complex and potentially context dependent.
Okay. So maybe baseline EPO level is a factor, but the optimal cutoff or direction isn't totally clear yet from RWD alone. Any other predictors?
Yanosova's study added another layer, connecting response to prognostic scoring systems. They noted particularly excellent responders among patients who had very low or low-risk scores, according to the IPSS-M, which is a newer system that includes molecular factors like gene mutations.
Ah, so incorporating genetics and molecular markers might be key?
It strongly suggests that, yes, using these more sophisticated molecular prognostic tools might really help refine patient selection for Luspatercept in the future. So while we don't have one single magic bullet predictor yet, these real-world signals, considering baseline transfusion burden, maybe EPO levels, though that needs clarification, immune cell counts, and definitely molecular risk scores, are helping clinicians build a profile of the patients most likely to benefit.
That's really helpful. Okay, one last area under clinical practice patterns, concomitant therapies. You mentioned earlier that the Jonas-Sova study saw high rates of response potentially linked to combining Luspatercept with ESAs. Is this combination strategy something that's popping up frequently in the real world? Because initial trials often focus on monotherapy.
This is indeed a fascinating area where real-world practice seems to be actively exploring approaches beyond the initial trial designs, really showcasing clinical ingenuity or maybe just pragmatism. The Jonas-Sova Czech study provides the most striking data here. They found that a really impressive 60.7%, nearly two-thirds of their patients received epoid and alpha, an ESA, simultaneously with Luspatercept at some point.
Wow, over 60% got both. Was this planned up front or added later?
It seems it was mostly added later. They reported that epoidin was typically added when patients weren't showing what clinicians felt was an appropriate response after they had already reached the maximum Luspatercept dose. So it was used more as an add-on strategy to try and boost or salvage a response.
A pragmatic approach to enhance benefit then. And did it work?
Well, they reported that a significant portion, 55.2% of their eventual responders, actually benefited from this combination therapy. This strongly implies a potential synergistic effect. You have Luspatercept working on later stages of erythropoiesis, addressing that ineffective maturation, and the ESA working on earlier stages, stimulating progenitor proliferation, hitting the red blood cell factory at different points, essentially.
Like a 1-2 punch for anemia. Makes sense biologically. Did other studies support this combination benefit?
The picture isn't entirely uniform. The Busla Greek and Turkish study also included some patients who received combination therapy. However, in their analysis, they did not find a statistically significant difference in response rates between those who got Luspatercept monotherapy and those who got the combination with an ESA.
Oh, okay, so conflicting data.
Potentially. But Busla and colleagues were careful to acknowledge that the number of patients receiving combination therapy in their study was quite small, which really limited their statistical power to draw firm conclusions.
Right. Small numbers make it hard to see a real difference if one exists.
Exactly. So this highlights a critical point. While these real-world observations, particularly from Jonas-Sova, strongly suggest a potential synergy and showcase pragmatic clinical use of combinations, we still need further, well-designed, randomized clinical trials to definitively establish the recommendations for combination therapy. Is it truly synergistic? In which patients? At what point should it be added?
It's that classic situation where clinical practice and observation can sometimes outpace the formal research, isn't it? Clinicians see a need, try a logical approach, and generate hypotheses that then need rigorous testing.
Precisely. It's like clinicians are conducting these real-time, pragmatic mini-trials in their own clinics based on patient needs, and the patterns emerging from that collective experience are incredibly valuable, even if they need formal confirmation.
Okay, fantastic overview of the practice patterns. So we've covered how effective and safe it is and the how clinicians are using it. Now let's look forward and also look critically. What new insights or maybe unexpected observations are emerging from these real-world studies? Where is the evidence still thin? And what are the crucial questions that remain for the future? Let's start with any novel endpoints or observations.
Yeah, beyond just confirming or refining what we knew from trials,
Mm.
real-world data can sometimes shed light on other important benefits or even hint at underlying mechanisms. One key area, which we've touched on but deserves highlighting again, is the impact on iron overload markers.
The ferritin reduction?
Exactly. Several studies, including Bushla, Zhang, and Torti, consistently observed those significant reductions in serum ferritin levels, specifically in patients who responded hematologically to luspatercept.
And why is that so significant again?
Because chronic transfusion dependence inevitably leads to iron overload, and that iron overload is toxic. It damages vital organs over time. So seeing ferritin levels drop, as Torti reported with a 34% reduction after just 4 cycles in thalassemia patients, isn't just a change in a lab number. It's a direct impact on mitigating a major long-term health risk associated with the underlying disease and its traditional management. It's a huge practical benefit.
Got it. A really tangible secondary benefit. What else was novel or unexpected?
Well, another interesting area, as we briefly mentioned, was the potential impact on other cell lines beyond just red blood cells. Busla's study observed that overall increase in neutrophil counts across their whole cohort and also saw some platelet responses in patients who started with low platelets,
hinting at broader bone marrow effects.
potentially. While Zhang's study didn't find significant differences in the magnitude of platelet or white cell increases between responders and non-responders, the fact that these parameters are being tracked and sometimes show improvement is interesting. It hints at possible multi-lineage effects that might warrant further investigation. Could luspatercept be doing more than just promoting red cell maturation? It's an open question suggested by these real-world observations.
Okay. And how do these real-world findings, particularly the suggestion of combination therapy with ESAs, fit with the results of the COMMANDS trial, which showed luspatercept was actually superior to an ESA as a first-line treatment?
It's a key point of evolving understanding and highlights how different settings ask different questions. The COMMANDS trial established luspatercept's superiority over epoetin alpha when used as the initial therapy for ESA-naive LR-MDS patients needing red cell transfusions. That's a clear head-to-head comparison for first-line treatment.
Right. Luspatercept won the first-line battle.
Correct. But what the real-world studies, particularly Jonas-Sova's, are showing us is a different scenario. They demonstrated improved response rates when luspatercept was combined with epoetin alpha in patients who weren't fully responding to luspatercept alone, often after failing prior ESAs or needing dose escalation.
So not first-line, but maybe second-line or salvage combination.
Exactly. It suggests that even if luspatercept is superior first line, there might be a role for synergistic action by targeting different stages of erythropoiesis in patients who have an incomplete response to single-agent therapy later on. It implies it's not necessarily an either situation across the entire treatment journey. Clinicians are clearly exploring these combinations pragmatically in later lines of therapy.
Which is an important insight that a first-line trial wouldn't necessarily capture, right?
Precisely. It means for some patients, particularly those with refractory disease, the best approach might involve a tag team effort from different agents, rather than relying solely on sequential monotherapy.
Makes sense. Okay, looking forward then, where are the biggest gaps in our current real-world evidence base for luspatercept? What are the crucial areas where we still need more robust data to really understand its full potential and also its limitations?
Despite the wealth of data we've discussed, there are definitely several significant gaps that the current real-world studies haven't fully addressed yet. These really point the way for future research priorities.
What's top of the list?
One major area is pediatric use. Almost none of the real-world studies we looked at provided substantial data on pediatric patients. While Torti's study mentioned young patients as a selection criterion for thalassemia, the median age across most of these MDS and thalassemia studies was still firmly in the mid-70s. Understanding efficacy, safety, and dosing in children and adolescents with these chronic conditions remains a critical unmet need.
Okay, pediatric data is missing. What else?
Another significant gap is robust long-term safety data, especially beyond 12 to 18 months. While some studies had median follow-ups approaching that mark, Jonas-Sova at 17 months, and Gritzels around 15 months, Bushla around 13, Lanino around 12.5, truly multi-year safety data from the real world is still evolving. Farouk's study, for example, had a median response duration of 6 months within only a 12-month follow-up window.
So we don't really know what happens after 2, 3, 5 years of continuous use in the real world.
Not comprehensively, no. We need more extended, dedicated follow-up registries. These are crucial to fully understand the long-term durability of response, to watch for any potential rare or late-onset adverse events, and also to understand patterns of disease progression or transformation over many years of therapy. This long-term perspective is absolutely essential for patient counseling and planning.
Agreed. What other gaps are there?
We also have relatively limited specific data on its utility in patients who are ESA refractory but still transfusion-independent MDS. While several studies, like Andritsis and Zhang, did include non-transfusion-dependent patients at baseline, the primary focus in most research, understandably, remains on the transfusion-dependent populations where the need is greatest.
So we don't know if luspatercept can keep someone off transfusions if they're failing ESAs but not quite dependent yet.
We need more specific real-world data to evaluate that precise role. Can it effectively maintain non-transfusion dependence and delay that progression to regular transfusions in that specific pre-transfusion dependent ESA refractory niche? It's an important clinical question. Also, the impact of concurrent mutations beyond just SF3B1 needs much deeper exploration. Donosova noted those excellent responders among patients with low-risk IPSSM scores, which incorporates molecular data, but they rightly suggested further research is needed on how other specific concurrent mutations might influence treatment responses, and we need that in larger cohorts.
Getting deeper into the molecular drivers of response.
Exactly. Moving towards even more personalized medicine based on a patient's unique genomic profile. And finally, specifically for Thalassemia, while Torti's study hinted at better responses in non-beta 0 genotypes, we really need more extensive real-world data to provide robust support for genotype-specific efficacy and safety. Can we confidently say certain genotypes will respond better or worse? That would allow for much more precise and tailored treatment recommendations in thalassemia, moving beyond a one-size-fits-all approach for that inherited disorder.
Okay, that's a clear set of areas needing more work. Pediatrics, long-term safety, the TI but ESA refractory group, deeper molecular correlations, and genotype specifics in thalassemia.
Precisely. Lots still to learn, as always.
Indeed. Okay, let's start to wrap this up. We've covered a huge amount of ground, digging through all this real-world evidence.
We really have. And if we try to connect all these threads back to the bigger picture, I think it's fair to say that across these diverse real-world studies, Luspatercept has consistently demonstrated remarkable effectiveness in reducing transfusion needs and improving hemoglobin levels for many patients with lower-risk MDS and transfusion-dependent thalassemia. It's clear this drug has really cemented its place in real-world clinical practice since its approval.
So can you summarize for us again some of the most consistent and impactful findings that really stand out from this deep dive into the RWD?
Absolutely. I think 4 or 5 key themes emerged strongly. First, significant transfusion burden reduction. We consistently saw luspatercept reducing transfusion requirements, often leading to periods of transfusion independence, especially, as we noted, in patients starting with lower baseline transfusion needs. Second, this often comes hand in hand with notable increases in pre-transfusion hemoglobin levels, which, as we discussed, directly translates to improved energy and less fatigue for patients, impacting their daily lives. Third, the safety profile appears generally manageable. Most adverse events reported in the real world are mild to moderate things like fatigue, dizziness, musculoskeletal pain, transient hypertension, and seem consistent with the clinical trial data. However, a key real-world learning is a need for close monitoring for thrombocytosis, particularly in thalassemia patients, emphasizing that need for tailored vigilance. Fourth, and this is a huge practical benefit, responders frequently showed that significant reduction in serum ferritin, tackling the problem of iron overload, which is vital for preventing long-term organ damage in chronically transfused patients.
And perhaps most critically for everyday practice, these studies collectively demonstrate strong real-world feasibility. Luspatercept is being used effectively in the typical patients we see: older, more comorbid, often heavily pretreated, reflecting its broad applicability beyond the sometimes restrictive selection criteria used in clinical trials.
That's a fantastic summary. So, based on all that, where does luspatercept seem most valuable in the clinical trenches right now?
Based on this RWD, it seems particularly valuable in several key settings. Certainly for patients with lower risk MDS who have failed or are unsuitable for ESAs, and now that's regardless of their ring sideroblast status, thanks to the commands data and the RWD supporting its use more broadly. Also, clearly valuable for those LRMDS patients who specifically have SF3B1 mutations. For transfusion-dependent thalassemia, it offers a crucial option, especially perhaps in those with specific genotypes that respond better, or in patients who face significant challenges with transfusion therapy itself, like alloimmunization or poor venous access. And the RWD strongly suggests it's valuable in cases where clinicians employ dose escalation, pushing to the maximum dose if needed, and potentially where combination with ESAs is considered to enhance or salvage a response in later lines. And fundamentally, it's valuable for any patient where reducing that transfusion burden can dramatically improve their quality of life and potentially mitigate those dangerous long-term complications of iron overload.
That really clarifies its place. What stands out most to you from digging through all this real-world data? For me, it's just the incredible way this kind of evidence highlights nuances and practices that the pristine environment of a randomized controlled trial might completely miss. It shows us how a drug truly functions, warts and all, in the diverse, unpredictable reality of patient care, not just in a controlled lab setting. It's truly eye-opening, I find.
I completely agree. That's the unique power of RWE. It bridges that gap between trial efficacy and real-world effectiveness.
Looking ahead then, the future directions seem pretty clear based on the gaps we identified. That encouraging real-world observation about combining luspatercept with ESAs, especially from the Yonisova study, it just screams out for further randomized clinical trials, doesn't it? We need to establish definitive recommendations and really understand the underlying synergistic mechanisms. Is this the new standard for some patients or just a salvage option?
Absolutely. Dedicated trials for combination strategies are a high priority.
And the need for comprehensive long-term registries is also crystal clear. We need to gather more robust data on the durability of response, long-term safety, rare adverse events, especially beyond that initial 12 to 18-month window. That gives us the crucial information needed for responsible long-term patient management and counseling.
Agreed. Long-term follow-up is essential.
Furthermore, continued validation of those potential predictive biomarkers, things like baseline serum EPO levels, though we need clarity there, maybe ALC and AMC, and certainly integrating molecular profiles like the IPSSM score that could enable much more personalized patient selection and treatment optimization. Moving towards true precision medicine for these anemias.
The Holy Grail, yes. Getting the right drug to the right patient at the right time.
And, of course, we need dedicated studies to address the specific data gaps we outlined. Pediatric populations, the ESA refractory but transfusion-independent MDS group. Those areas need focused research. And finally, I think it's essential we continue gathering inclusive real-world evidence from really diverse geographic regions, especially including low-resource settings. We need to understand the unique challenges related to access, adherence, cost, and local practice patterns globally. Because a drug that works wonders in a high-resource healthcare system might face entirely different hurdles elsewhere.
That's a critical point about health equity and global applicability.
Definitely. So let's leave our listeners with this thought to ponder. Given the diverse real-world outcomes and practice patterns we've seen today with luspatercept, how might a deeper, more integrated understanding of each patient's unique biological landscape, their genetics, their comorbidities, combined with their logistical landscape, their access, their support systems, shift our approach? Can we move from our current, often standardized treatment pathways towards a truly personalized erythroid support strategy for every individual patient? That's a question for all of us in healthcare to think about as we move forward. Thanks for joining us on The Deep Dive.